Enzymes. So enzymes, by definition, are a biological protein that catalyze biochemical reactions without undergoing permanent changes themselves. So their role is the reactions catalyzed by enzymes are essential for physiological functions. Enzymes are distributed and found in all body tissues. Their clinical relevance, so enzymes appear in serum after cellular damage, and serum enzyme levels are useful for diagnosing diseases or abnormalities. So isoenzymes are different forms of enzymes within the same family. So an example of that would be creatine kinase, or CK, and isoenzymes, and that includes CKMM, CKMB, and CKBB. The cofactor is a non-protein molecule required for enzyme activity. And then activators are an inorganic cofactor such as chloride or magnesium ions that enhance enzyme activity. And then a coenzyme is an organic cofactor such as NAD, which is needed for enzyme function. Enzyme kinetics, so the chemical reactions require energy to proceed. This energy is called activation energy. Enzymes provide activation energy, and the enzymes help start and speed up chemical reactions by lowering the activation energy needed. Increasing temperature can provide more energy. This also helps speed up reactions but has limits due to enzyme denaturization. So the basic reaction mechanism, there is an equation there. You don't necessarily need to memorize this, but E stands for enzyme, S is for substrate, ES is the enzyme substrate complex, and P is the product. So enzyme specificity types, we have absolute specificity. So one enzyme binds to one specific substrate only. And then we also have group specific, where the enzyme binds to substrates that share a particular chemical group. Factors that can affect enzyme activity. So we have substrate concentration. That's the amount of substrate available that affects the rate of enzyme activity. Enzyme concentration, that's the amount of enzyme present that influences how quickly the reaction can proceed. pH, so enzymes have an optimal pH range. Deviations can reduce activity or denature the enzyme. Temperature, once again, enzymes function best at an optimal temperature. Too high or too low temperatures can reduce activity or cause denaturization. Cofactors are non-protein molecules or ions that are necessary for the enzyme activity, and inhibitors are substances that reduce enzyme activity by interfering with the enzyme or substrate. So substrate concentration, when enzyme amount exceeds substrate amount, the reaction rate steadily increases as more substrate is added. So the first order kinetics, the reaction rate is directly proportional to substrate concentration. So more substrate equals a faster reaction. A zero order kinetics, a reaction rate will depend only on enzyme concentration, not the substrate. This is the desired state for enzyme assays. So ideally, the reaction rate should depend only on the amount of enzyme to be able to accurately measure the enzyme activity. Factors that can affect enzyme reactions, which we already kind of mentioned. So pH. So most enzyme reactions are going to occur at the pH level between 7 and 8. Buffers are used to help maintain stable pH conditions. Temperature, once again, increasing temperature can increase reaction rate. Optimal range is no higher than 40 to 50 degrees Celsius, and higher temperatures can cause enzyme denaturization. Cofactors may be essential to or enhance enzyme activity. Some examples of that are calcium, iron, magnesium, potassium. Coenzymes act as a second substrate in reactions, and that is the NAD to the NADH. Inhibitors, so there are types of enzyme inhibition. So competitive inhibition, inhibitor will bind to the enzyme's active site, and that will directly compete with the substrate. It can be overcome by increasing substrate concentration. Non-competitive inhibition, so inhibitor binds to an alternate site, and it changes the enzyme shape, which prevents the substrate binding. It cannot be overcome by increasing substrate concentration. Uncompetitive inhibition, this inhibitor binds only to the enzyme substrate complex. This blocks the reaction from forming the product. So to measure the enzyme activity, we use a photometric method. And what can be measured is an increase in product concentration, a decrease in substrate concentration, a decrease in coenzyme concentration, or an increase in altered coenzyme concentration. So some requirements for this to happen is using zero-order kinetics. So the rate is going to depend only on the enzyme concentration, not on the substrate or coenzyme. So the substrate and coenzyme must be in excess, and reaction typically completes in 6 to 8 minutes. Enzyme activity assay methods. So we have fixed time or an endpoint assay, and how it works is you mix an enzyme plus a substrate, and that allows the reaction to proceed for a set amount of time. You're going to add a stop reagent, which helps stop or halt the reaction. And then we're going to measure the product formed or substrate used. The limitation is it's a single measurement, and we may miss early or late reaction changes. And then we have the kinetic or the continuous monitoring assay. And how it works is it takes multiple readings over time or continuously monitor absorbance or product formation. Advantage of this method is it gives better picture of the reaction rate, and it also allows detection of nonlinearity, lag faces, or substrate depletion. Enzymes aren't just measured. They can also be used as reagents to analyze non-enzymatic substances by catalyzing specific reactions that can produce measurable products. So examples of this would be a hexokinase, which is an enzyme, and that is used to measure glucose. Glucose oxidase is another method to help measure glucose. Cholesterol esterase and lipase are used for cholesterol analysis. So these enzymes help convert analytes into detectable product, so colored or fluorescent type options, and they are often measured photometrically. All right, so enzymes of clinical significance. We have the cardiac section or the heart section. So we have CK, which is creatinine kinase, CKMB, which is the creatinine kinase MB isoenzyme. We have LD or LDH, sometimes it's called, is lactate dehydrogenase. Troponin and myoglobin are listed on there, but they are not actually enzymes, but they are a marker used for cardiac. And then we have liver ones. We have AST, which is aspartate aminotransferase, ALT, which is alanine aminotransferase, GGT, which is gamma glutamyl transferase, and ALP, which is alkaline phosphatase. Bone can also be ALP, which is alkaline phosphatase. It's the bone isoform option. And then we have the biliary tract or the bile duct option, where we have the GGT. Prostate has ACP or acid phosphatase, and PSA is listed on there, but that is not an enzyme either. That is a marker for prostate. And then we have pancreas. We would use amylase and lipase. So creatinine kinase, its function, it's involved in ATP regeneration for the contractile system, so muscle contraction. It is also used in the transport system, so like ion pumps. Tissue sources where this could be found is cardiac muscle, skeletal muscle, and brain tissue. Clinical significance for this is increased CK can be seen in acute myocardial infarctions, Duchenne muscular dystrophy. So with that, CK can be 50 to 100 times of the upper limit of normal. So that much, 50 to 100 times higher than what it should be. The CKMB isoenzyme is most specific isoenzyme for cardiac disorders. A normal CKMB is less than 6% of the total CK. And then in a heart attack, total CK will increase, and your CKMB is actually going to be greater than 6% of the total CK. Excuse me. The timeline, so after someone has had an acute myocardial infarction, the CKMB is going to rise 48 hours post-onset. It will peak about 12 to 24 hours afterward, and about 48 to 72 hours, it will return to normal. So methods of testing, we can use the hexokinase, glucose 6-phosphate dehydrogenase, and NADP, lactate dehydrogenase, or LD or LDH. So in an acute myocardial infarction, this will increase 12 to 24 hours after. It will peak about 48 to 72 hours after, and it'll take about 10 days for it to return back to normal. It is longer lasting than the CKMB and troponin. It can also be markedly increased in people that have acute lymphoblastic leukemia. LDH has isoenzymes, so the LD1 is for your heart and red blood cells. LD2 is for the reticuloendothelial system. LD3 is lungs. LD4 and LD5 are liver and skeletal muscle. For an AMI indicator, you can do the LD flip. So LD1 is going to be higher than the LD2, and that is going to be suggestive of a heart attack. If you have a pulmonary infarction, your LD3, which is lung specific, is going to be increased, and then LD4 and LD5. If you have liver issues, those will be the ones that will be increased. AST, or aspartate aminotransferase, its function is to catalyze. It catalyzes the transfer of amino groups between aspartate and alpha keto acids. It is found in tissues of the cardiac, liver, and skeletal muscles. Clinical use, we can use it for acute myocardial infarctions, people with hepatocellular disorders, and skeletal muscle damage. Other increases can be seen in people that have pulmonary embolisms and congestive heart failure. The highest levels are going to be hepatocellular disorders, viral hepatitis. They can be up to 100 times above the normal limit. People that have cirrhosis will be about 4 times the normal limit. For sample handling, we want to avoid hemolysis as this can affect results. And the reference range is usually between 5 to 30. ALT, or alanine aminotransferase. It is an enzyme that's involved in amino acid metabolism. It specifically catalyzes the transfer of an amino group from alanine to alpha ketoglutarate. This reaction produces pyruvate and glutamate, which plays an essential role in the gluconeogenesis pathway and nitrogen metabolism. So the biochemical role, the function, ALT facilitates the transfer of the amino group from the alanine to alpha ketoglutarate, which forms pyruvate and glutamase. This reaction is vital for amino acid catabolism and maintaining nitrogen balance within the body. So tissue distribution, primary tissue, it's found, ALT is going to be mainly found in the liver. The way I kind of always remember it is AL, liver. It's a liver enzyme. There's an L in there. I don't know. This is how I remember it. Specificity, it is the most specific enzyme marker for liver tissue, making it a valuable clinical tool to help assess the liver health. Clinical significance, you have elevated levels. Increased ALT levels will generally indicate hepatocellular damage or liver inflammation. So some conditions that this would be, if there's an increased ALT, so hepatocellular disorders like hepatitis, cirrhosis, and liver injury. Inflammatory conditions also that are affecting the liver can cause an increase as well. ALT level dynamics. So ALT levels tend to be higher and remain elevated longer than other liver enzymes during liver injury. So this makes it a pretty reliable marker for ongoing liver damage. The reference range is typically between 6 to 37. Values exceeding this range may warrant, additional investigation to find out if they have, liver disease or liver damage. The biochemical function, the role of ALP is to function to remove phosphate groups from organic phosphate esters, a process which is critical in many physiological pathways, including bone mineralization. This is ALP, so alkaline phosphatase. Activator, we use magnesium ions. They're essential for ALP's enzymatic activity. For tissue distribution and clinical relevance, we have primary tissues. So the ALP is mainly found in the liver and the bone. Osteoblast activity, so within the bone, the ALP serves as a marker of osteoblast activity and bone formation. Liver function, so in the liver, ALP is associated with the hepatobiliary system, especially with the bile duct function. So some clinical significance of this, so elevated ALP levels, increased ALP can indicate, a whole bunch of different hepatobiliary and bone disorders, but this could be like a bile duct obstruction, cholestasis, liver disease, things like that. Flip to the bone side, this could show, if it's increased, that you have osteoblast activity like Paget's disease, bone metastasis, like a cancer in the bone, or healing fractures. So somebody broke their bone, they could have an increased ALP. Diagnostic use, so measuring ALP helps to differentiate between bone and liver pathology when interpreting with other tests as well. This is another one of those tests where they'll be a little bit higher in children because they're growing, so their bones are growing, right? So generally in the lab, kids are going to have a higher normal reference range than an adult would for this test. Biliary tract obstruction, again, if it's an elevated ALP, for biliary tract obstruction, ALP levels will typically increase 3 to 10 times above the normal limit. This is due to cholestasis, where bile flow is impaired, and that causes ALP to accumulate. In bone disorders like Paget's disease, excessive bone remodeling leads to increased osteoblast activity and high ALP. Osteomalacia and rickets, it's a disorder of defective bone mineralization with increased ALP as the bone turnover kind of rises. Hyperparathyroidism, so increased parathyroid hormone stimulates bone resorption and formation, which also raises ALP levels. We mentioned earlier healing fractures. So bone repair involves osteoblast activation, and that would once again elevate the ALP temporarily. Like I mentioned earlier, kids with growth spurts, increased osteoblastic activity can also lead to a higher ALP in children. Physiological increase for ALP, pregnancy. You'll find that a lot. Pregnancy kind of messes with a lot of things. ALP levels in pregnancy are going to be elevated, and that's because the fetal bone is developing and because the placental production is happening as well. To test for ALP, we will use the assay Bowers and McComb method. The principle of this is based on the enzymatic activity of the ALP on the P, bear with me here, nitrophenyl phosphate to release P nitrophenyl, which is measured colorimetrically. Some pre-analytical considerations, hemolysis can affect the results, so make sure we don't have a hemolyzed specimen. Also, ALP can be increased during storage of the sample, so we want to make sure these samples are processed as soon as possible to help ensure that accuracy of the results. The reference range is usually between 30 to 90. Acid phosphatase, the function, the enzyme that hydrolyzes phosphate esters in an acidic environment, which is usually about pH of 5. Tissue sources is the prostate gland. That's the major source in males. It's also found in the liver, spleen, bone marrow, and erythrocytes. Clinical significance, so historically this is used as a tumor marker for prostate cancer, but nowadays the PSA is used much more, and we'll talk about that test later. But elevated levels can be seen in prostatic carcinoma and bone metastasis. It can also be increased in other conditions that are affecting the liver or the bone marrow. Assay considerations, so measurement of enzyme activity in the serum or tissue samples requires acidic conditions for the activity to occur. The reference range is typically low in serum, and it's going to vary pretty wildly by lab and in the methodology that's being used. Gamma glutamyl transferase, or GGT. This is usually found in the tissue in the liver and biliary system. Clinical significance of this is it will be increased in all hepatobiliary disorders. It'll be especially high in the biliary tract obstruction, and it's going to be elevated with use of certain drugs such as warfarin, phenobarbital, and phenytoin. It will also serve as an indicator of alcohol abuse, because it affects your liver. So it's kind of telling on you. You have diagnostic utility. We use this for diagnosis. It helps differentiate causes of increased alkaline phosphatase. So if both your ALP and GGT are elevated, this will suggest usually that there's something going on with your liver. If ALP is elevated but GGT is normal, that would often suggest that it's just the bone that's having an issue. Reference ranges are usually between 6 to 45. Amylase, it functions as a catalyzes the breakdown of starch and glycogen. It is usually found in the pancreas and salivary glands. Clinical significance is its increased levels in urine and serum when patients are having an acute pancreatitis. So combining amylase clearance tests with lipase provides a better diagnostic accuracy for these patients. In acute pancreatitis, amylase will rise within 2 to 12 hours and it's going to peak at about 24 hours. It will return to normal in about 3 to 5 days. But it's also been noted that AIDS patients also have an increase in amylase. Lipase hydrolyzes ester linkages of fats to produce alcohols and fatty acids. It is found in your pancreas. Excuse me. Clinical significance is increased levels are used in the diagnosis of acute pancreatitis. Lipase is more specific than amylase for pancreatic disorders. Method is the Cherry and Crandall method. Precautions, you avoid hemolysis because it can cause falsely low results. And reference range is usually 0 to 1 units per liter. All right, cardiac disorders. As I mentioned before, we will talk more about cardiac stuff in chapters ahead of here. But just for now, so we have key enzymes and proteins. You have your CK&B, which is your creatinine kinase MB. So it'll indicate a myocardial infarction. It can also indicate if there's not, a heart issue, if it's less than 6% of the normal LD isoenzyme. LD, lactate dehydrogenase. If your LD1 is greater than your LD2, that supports an AMI diagnosis. Troponin 1 is the most useful marker because it is not elevated in any other conditions. That is strictly cardiac only. So a lot of times now in hospitals, they're doing just a troponin. They're not doing the CK&B or anything else. Testing protocols, serial measurements are going to be taken every 6 hours for the first 24 hours, and then generally it'll go every 12 hours for the next 48. And this is just to kind of help see those rise and fall. That way they can get confirmation of what actually happened. Hepatic disorders and enzymes. So you'll have an increased enzyme, your AST, ALT, GGT, and ALP. So your ALT will be have higher levels and will remain elevated longer than your AST. GGT is going to be the most sensitive indicator for all types of liver disorders, but especially the obstructive disorders. Skeletal muscle disorders, it's going to be the highest elevations of the CK or the creatinine kinase, especially with Duchenne type muscular dystrophy. For your ALP and bone disorders, ALP will be increased in these bone disorders. So Pegget's disease, it's a rapid resorption of bone by osteoclasts, compensatory increase in osteoblastic activity to help try to form new bone. Also in vitamin D deficiency, which causes rickets in children and causes osteomalacia in adults. ALP levels in children, increased in young children. At 10 years old, the ALP can be 4 times what the adult level is. Peak level for girls is between 11 and 12 years old, and boys is between 13 and 14 years old. Acute pancreatitis enzyme levels, so serum and urine amylase. Serum amylase increases early, like within hours after onset of acute pancreatitis. Urine amylase is going to remain elevated longer than the serum amylase. So your serum amylase will return to normal, like I just mentioned, faster than the urine. Lipase levels, this is more specific and sensitive for pancreatitis diagnosis. It will remain elevated longer than amylase as well. Amylase creatinine clearance ratio, the normal range is 2 to 5%. This will be increased in patients that have acute pancreatitis. And it is useful for distinguishing pancreatitis from other causes of elevated amylase.